topic for today is basically the use of Tovactans. Uh, what is the concept behind it, and what are the recent advances in use of Tovactans? Okay, so what we'll be doing at this moment is we know that tolvaptan and that V2 receptor antagonists are very commonly prescribed in day-to-day prescription of ours, including uh, in hyponatremia cases, not only in the critical care ICU, but also in uh, areas like emergencies or uh, any ward of which is catering to the population, not only surgical population but also medical population. So hyponatremia itself is a separate chapter, so we'll not be discussing more about hyponatremia since Arindam wants to do it at a later period of time. So what I'm trying to do in this lecture will be that use rationalization of use of tolvaptan or the Vaptans in clinical scenarios like hyponatremia. So before going to that, I want to focus on the concepts. So as you know, uh, that hyponatremia can be divided into true hyponatremia or false hyponatremia. Okay. So in the true hyponatremia, those could be hypoosmolar or hyperosmolar. And in the hypoosmolar group, this algorithm is like this, that everywhere it is represented the similar way, that in hypoosmolar group, you will have to divide them into hypovolemic, euvolemic, or hypervolemic. And we know that there are certain conditions where hypovolemic hyponatremia are prevalent. Uh, and we know that GI loss of electrolytes in certain scenarios like diarrhea is more, where if you give hypotonic solution to the patient, then patient presents with hyponatremia. Likewise, those patients who are having excessive sweat, like the marathon runners, if you are utilizing hypotonic uh, solution to them during drinking process, then they can develop hyponatremia, which could be a life-threatening condition sometimes. So patient might collapse during marathon run, and keep it in mind that those people who are marathon runners, when they ask for water to drink or any liquid to drink, don't give only water, Bisleri bottles. So it has to be a salt containing fluid. So that way we can make it isotonic to our plasma and drink it. Then you know about renal fluid loss due to diuretics and other things, which can create hyponatremia, which is also intravascular volume depletion is one of the component of it, that is hypovolemic. And the euvolemic starters we find in SIDH, hypothyroid state, and Addison's disease, and out of which most convenient way of representation in most of the situation is SIDH in patients, whether it is true or it is false diagnosis, but most of often we use the term that is called as SIDH. Mind you, SIDH should not be confused with hypovolemic hyponatremia, where the ADH secretion is appropriate for your condition. That we cannot label it as SIDH. When the ADH secretion should not be there and you are experiencing high ADH secretion, in that scenario, you call it as syndrome of inappropriate ADH secretion, that is SIDH. There is another concept of hypervolemic hyponatremia. So those people you tend to retain salt as well as water, but the water absorption is much more, retention is much more higher than the salt retention. So in that scenario, obviously the hyponatremia will be prevalent. And for each of the conditions of hyposmolar hyponatremia, the treatment will differ. So that's why this this is very much required in during our clinical practice, that which condition is prevalent in that patient, or is it a mixture of the condition. So going into the concept of hyponatremia, I'm just giving you a brief scenario where you can see here that the serum sodium is around 140 milliequivalents per liter, but that is basically when you compute and you find out, then it is coming as 129 milliequivalent per liters, which gives you an indication of hyponatremia. Since below 135, you call it as 130 hyponatremia if the plasma osmolality will be less than 260 milliosmoles per liter per kg, sorry. So here, what I wanted to emphasize here is that if the normal plasma is 140 milliequivalents per liter, it has got two components. One is the solid component and one is the aqueous component. And when we were utilizing earlier a test that is called as flame photometry, so it cannot differentiate between the solid phase and the aqueous phase. Whereas nowadays that the test which has been used, or the investigation which has been used for sodium concentration determination, is by ion specific electrodes. So this hyponatremia is never a problem, means fake pseudo hyponatremia is never a problem with current standards of ion exchange electrodes. However, when the flame photometry was there, so at that point of time, this things basically represents, if you are excluding this solid phase, then you can see that there is a miscalculation of the sodium that is called as pseudo hyponatremia. So 129. So here there is another example of how solid phase also contributes towards your significance towards hyponatremia. Basically, if there is a hyperproteinemia or hyperlipidemia, basically the hypertriglyceridemia, then if you are using flame photometry, then it can miscalculate and give you a false representation of sodium concentration. So nowadays with ion specific electrodes, the concept of fake pseudo hyponatremia has been reduced. Now coming to normal saline, why we are calling it as normal saline when our calculation says that it is a hypertonic solution. So how to calculate? We use 0.9% normal saline, which is around 0.9 grams in 100 ml. So that represents that 9 grams of sodium chloride in 1000 ml 1 liter of aqueous solution of saline, and 9 grams if you divide into molecular weight, that gives you the mole, that is 58.5 is the sodium plus chloride together, and the that comes to around 0.154 moles per liter, and converting it is coming as 154 millimoles per liter. So why we call normal saline as normal saline? Why not? It is a hypertonic. Actually, should be a hypertonic saline. So this is how it is calculated. So when we were using flame photometry, as I said earlier, that we are using the solid phase and the aqueous phase, or the solid phase was not calculated at that point of time. So 154 milliequivalents into 0.92 liters, that is the 8%. If you deduce it, then it comes to around 141 milliequivalents per liter. So that is how the concept of 140 milliequivalents per liter to 145 milliequivalents per liter of sodium concentration was proposed, since we were using 20 years back flame photometry as one of the investigation tool. Whereas after the the iron specific electrodes came, so that error was abolished. However, we were in our mindset, we have kept our sodium value as 140 to 155 milliequivalents per liter in our mind, which is normal. We call it everywhere in the world. So changing over from 140 to 145 to 154 is a little bit difficult. So always there is a intrinsic calculation happens in that machine where there is a multiplying factor, and that multiplying factor normalizes that sodium level to our current form. So that's why, so normal sodium concentration in our plasma is actually 154 milliequivalents in ion exchange. However, that's why we call it as normal saline. However, that investigation approach was different earlier, and current standards are different. That's why the 140 milliequivalents to 145 milliequivalents were kept as a normal sodium concentration in our plasma. Next, coming to, this is the same thing. Next, coming to the causes of hyponatremia, I'm just going in brief, since everybody might not be familiar with the concepts, how the pictorial form, how it has been represented. So it is basically one of the articles which are very much famous in, that was in 2000, NEJM article by Dr. Nicholas Medius. So if you take into account here the extracellular fluid and intracellular fluid, we know that the total body water will be distributed in 2/3 in the intracellular fluid, and extracellular fluid will be 1/3, and out of which 1/3 will be intravascular and the 2/3 will be interstitial. So and the white dots, what you are seeing here is the sodium cation, and the black dots, what you are seeing here is the potassium as cation. So the true hyponatremia is when the water retention happens, which will expand both the extracellular fluid as well as intracellular fluid, whereas though there will be no change in the cations in the intracellular or extracellular fluid. Whereas if there is any anticipated hypoosmolality due to renal failure, since urea is considered to be one of the osmotically active agents, so there you will see that there is a increase volume of dragging of water in the intracellular as well as extracellular compartment, and that is causing hyponatremia, which is we call it as dilutional hyponatremia. The other form of hyponatremia is hypertonic hyponatremia, is due to hyperosmolar state, especially hyperglycemia. So you can see here the black square is glucose molecule, which will drag water from the intracellular fluid into the extracellular fluid and thereby causing hyponatremia, and there will be intracellular shrinkage of cell wall, cell membrane. Sorry. The third one, the E1, is hypotonic hyponatremia, is due to the water loss, but water and salt loss, but more of hypotonic intake of fluid, which will cause expansion of intracellular fluid, whereas the intravascular and interstitial fluid compartment will be shrunk. Similarly, the nephrotic syndrome will see that the salt in both sides, salt and water, especially the salt in sodium salt will be gain will be there, and along with that the water will be absorbed, and that is seen in nephrotic syndrome. And the last part is the heart failure with diuretics, where you will see that potassium loss will be there, and there will be shrinkage of intracellular fluid compartment, whereas there will be due to the renin-angiotensin aldosterone axis, the sodium also will be increase in sodium gain will happen. Along with that, the water will be absorbed, and that will cause dilutional hyponatremia with hypokalemia. So these are some of the causes of hyponatremia you can find in that good article, which you can go through. And there is also another one which has been written by the same group, Dr. Nicholas Madias, about hyponatremia as well, in the second edition of NEGM in 2000. So you can go through that. Now, what is your response, normal physiological response to the osmolality? So usually when the plasma osmolality is less than 280, at that point of time, the vasopressin secretion will be low. It almost goes into nil. Whereas when it goes up, the vasopressin starts released from the posterior pituitary. It is synthesized from the hypothalamus and stored in the posterior pituitary, and then subsequently it causes water retention, water absorption. So you can see here that when the osmolality increases in your plasma, likewise the ADH also will be increase in the secretion, and similar wise urinary osmolality also will increase, telling that there is a water concentration. So what is your basic physiology for this current phenomenon of water handling of our kidney? There are 4 elements which will be required for excretion of free water. And as I said earlier in the causes, that it is much more is the balance of water metabolism in which is in trouble rather than the salt itself. So hyponatremia most often is due to the problem of water balance than the salt related issues. So what are the concepts of the free water handling by our kidneys. So the first one is the glomerular filtration rate, which is the, if it is impaired in chronic kidney disease, obviously the water excretion also will be less and the solute excretion also will be less. So the GFR is the first one. Second one is the diluting segment. As you know, the diluting segment starts from the ascending, thick ascending loop of Henle, which is impermeable to water. And then the concentration happens in the distal convertile tubule or the collecting duct by the principal cells. So the ADH action happens here in the third concept in the collecting duct. This is just simplistic cartoon expression of what are the components of water handling in the nephron. The fourth one is the just I'm telling you when the urine goes into the collecting duct without ADH secretion. So the aquaporin channels will be closed. So whatever urine and salt and other solutes will be delivered in the final urine will be no water absorption will happen. Whereas if you say that there is a ADH secretion is happening due to some reason, then there is a complete, the urinary concentration happens and there is a very low volume of urine flow happens in the final part, and most of the water will be absorbed by the ADH into the body itself. So how it happens? So this has to be through a mechanism that is called as subtle hypothesis. So what is subtle hypothesis? Subtle hypothesis is basically a concept of water absorption by the collecting duct principal cells. And what it does, whenever there is a ADH release, so we have a specimen of the principal cells of the collecting duct here. So one is the luminal side, the other side is called as basolateral side. Okay, so which is the inside the tubules when the urine flow happens, that is called as luminal side. So the V2 receptor are present in the basolateral side of the tubule of the collecting duct. So when the ADH gets secreted, it it attaches itself to the V2 receptors and it causes some conformational changes in the V2 receptors, and the V2 receptor is a G protein coupled receptor. So it in turn will release cyclic GMP and ultimately it triggers the cyclic adenosine cyclase and cyclic AMP, and it causes the activation of aquaporin channels. And what is the aquaporin channels does? The aquaporin channel shuttles from the cytosol into the apical membrane into the luminal side and traps the water over there, and then comes back after trapping and goes and fuses into the basolateral side of the membrane and delivers that water into the peritubular capillaries. However, what is important to know here is that this subtle process, it is a subtle since again after coming back, joining the basolateral side, it goes into the cytosol in an inactive form, and if stimulated, again it goes and fuses into the apical membrane. So that's why it is called as subtle. So what is the importance of this is basically This is a aquaporin channel. Okay, so it is not a pump. What is the difference between a pump and a channel? The pump requires ATP, or ATP is generated inside the pump to put the solutes inside or outside, like like sodium potassium ATPase pump. So sodium potassium ATPase pump will, when triggered, will cause extrusion of sodium and inward extrusion inwardness of the potassium into the cell. So whereas the when it is not a pump, it is only a channel, it requires a driving force. And what is the driving force here? It is the medullary concentration gradient, which is the driving force. So that drives the water aquaporin channels to come to the cytosol and gets fused into the basolateral site. So the driving force basically is the medullary concentration tonicity. And we know that there is for maintaining the medullary tonicity, we require counter current multiplier system. So any uh, any process which causes loss of medullary tonicity, then this aquaporin channel shuttling will not happen. So that will be speaking it in a later period of time, how it happens in clinical scenarios, how it is different. Now, the fourth point is what the element which is required for electrolyte free water excretion is, or the handling is, the urea level. So urea is a osmotically active substance. So when it is present in the urinary system, it attaches over the urea molecule, the water gets attached and it excretes out as a free water or electrolyte free water. So there, in presence of antidiuretic hormone also, if the urea concentration is reasonably high in your urine, then electrolyte free water can be excreted out in the final urine. So how it is important for us? There are certain conditions where the urea generation gets affected. The most common conditions which has been described in our literature are basically, one is the beer potomania, where people tend to drink more beer and consume less protein. And the beer is basically alcohol, which is a free energy, and there is no protein itself. So that way the urea generation gets compromised and the liver cannot make urea, since there is an absence of protein in the diet, and that causes the decrease in the urea production. And finally, that urine beer obviously is a large volume, so ethanol obviously it gets degraded into alcohol, carbon dioxide, and water. So water absorption, which is gone inside your body, will cause dilutional hyponatremia. The other one which has been prevalent is in the foreign countries is tea and toast diet. What is tea and toast diet? The tea and toast diet especially are prevalent in elderly population who are not having any family with them. They are either isolated or they are in the old age home. So whatever the work they do, then ultimately they don't cook their meal, or once a while they cook their meal. Otherwise, what they consume is tea and toast diet. So that toast is obviously is a carbohydrate, which is uh, and it doesn't contain any protein. So whenever you consume with tea, so that causes reduced urea formation and it causes hyponatremia. The other which is a common variant is basically when a patient is uh, having any type of, especially seen in oncological practice, where the people doesn't take much of water, they take only juice or something like that, not protein. The food intake is reduced with them due to several factors, multiple factors, and that results in reduced protein intake, and later on they uh, uh, develop hyponatremia. And that hyponatremia could be multifactorial also. The uh, ADH secretion, SIDH can be also part of that, or any medication which can trigger hyponatremia, that also could be possible, like vincristine, cyclophosphamide, all those agents can trigger hyponatremia. Also, there is another thing which can retain, or the ADH gets triggered, is nausea and vomiting and the pain. So cancerous pain, if it will be there, so it causes ADH secretion, and they will be obviously taking liquid food, and then this cycle, vicious cycle goes on, and they present as hyponatremia. So these are some of the factors which you need to know before considering for the final water metabolism, how it is impairing our managing our life. So here it is almost the same. Fourth element. Now, in that article, which was given to us in 2000, at that point of time, you can actually calculate how much is the water excess in your body. And if you want to give any concentrated solution in the form of salt, and then probably you can see a rise in the sodium level. So this is the calculated formula for which they have given a, yeah, that these are some of the solutions which can be used. What is important here is the sodium content in millimoles per liter of the salt concentration in our different solutions which are available to us for for use in hyponatremia settings. However, you have to see that the volume of distribution of extracellular fluid. Okay. So why it is important? Dilution, if the patient will be given hypotonics solution, they will obviously the volume of distribution in the extracellular fluid will be less, whereas 5% sodium chloride or 3% sodium chloride or normal saline, all our extracellular fluid distribution will be 100%. We'll discuss about it at a later period of time, why it is important for us to know why it is required. Uh, this seemed to us basically a easy solution with a less complicated formula to calculate the sodium or the water deficit, and then subsequently treat the patient with hyponatremia. But this hyponatremia, which was thought about, was basically a management of acute hyponatremia setting, or nowadays which we call it as the hyponatremia where the brain is adapted, or hyponatremia which is not, brain is not, CNS is not adapted. So acute and chronic hyponatremia seem to be uh, the concept about that, about 24 hours and beyond 24 hours, that concept has been changed to new nomenclature. That is, whether the CNS has adapted to the hyponatremia or the CNS has not adapted to the hyponatremia. So with this simple calculation formula, we became happy that yes, we can calculate and give the appropriate therapy to correct the sodium level or treat the hyponatremia. So this is how uh, uh, the concept is, that if it is the body, your total body water is like a box, then you give infused sodium of this much, and that will give you a correction of hyponatremia. Let us see what is happening with us. In the intracellular fluid and the extracellular fluid, if you say that the cation, that is the sodium, is 140 milliequivalents, here in the that is, cation is basically sodium or potassium. They behave that similar way. So cation here in the intracellular fluid will be potassium, whereas in the extracellular fluid it will be sodium, and they are almost equivalent to each other. And volume of total body water, if you distribute, then extracellular fluid will be 1/3 and the 2/3 will be the intracellular fluid. So if we calculate roughly, if we say that it is 60 liters, it is just an example, then 40 liters will be distributed in the intracellular fluid and 20 liters in the extracellular fluid. Now let us add 66 liters of hypotonic fluid to the, or 5% dextrose, or any hypotonic fluid which you have drunk, that will be added to the extracellular fluid compartment. So what will happen next? The next is, if you calculate, immediately nothing will happen in the intracellular fluid compartment. In the extracellular fluid, since you have added 6 liters of hypotonic solution, then the cation will go down to 107 with 26 liters of volume. So what will be the next effect in our body? So always the cation in the intracellular and the extracellular will be balanced. So the cation here try to do some changes. How it will be? The water, which is the freely permeable solvent, will be moving from extracellular fluid to the intracellular fluid compartment. And that will dilute the intracellular fluid compartment cations and will bring down from 140 to 127. And similarly, extracellular fluid compartment, it will bring down to 127. And this is the volume in both the sides. And there will be a rise in 10% volume in the intracellular fluid compartment. Now, why it is very important for us? If it is an acute scenario, then the brain, which is inside the skull, it doesn't have the time to expand. So what will happen? There will be intracranial hypertension, or in ICT will raise. And that is a life-threatening condition, since tentorial herniation can happen in that scenario. So the idea of hyponatremia, which is not adapted to the CNS, is basically bring down the source, the intracranial pressure first, so that the tentorial herniation will not happen. So if you add the extracellular fluid compartment into the hypertonic fluid, let us say that 5% of the change in the sodium you want to have, then you require a 3% saline of around 300 ml to change your extracellular fluid tonicity by 5%. So what will happen next? The next is basically, there is since we know that the 5% dextrose will be, 5%, 3% saline will be distributed predominantly in the extracellular fluid, the volume will increase by 22.3 liters, which will cause increase in the cation, that is the sodium ion will increase 131 from 127. And what will happen next? There will be two, since the cation and will be equal in both sides, there will be movement of water from the intracellular compartment into the extracellular compartment, and that will reduce your brain edema. So that is how the concept is that 3% saline to be used in acute scenarios or those person who are symptomatic in hyponatremia. Whereas if the CNS is already adapted, then uh, there are certain other osmolytes which are the cells will show a protective phenomenon, and that gets extruded from the intracellular compartment to maintain the balance and reduce the intracranial tension. And those osmolytes are basically sometimes the myoinositol, then the choline, and certain other organic molecules, and the potassium. So those in due course of time, in acute scenario, it will not happen, but if the body will try to adapt to the situation, then osmolytes will be extruded from the intracellular compartment, that is the brain cells, and then go into the extracellular fluid compartment to reduce the intracranial tension. However, if you change the environment suddenly, like from sudden correction of hyponatremia will happen, that change will cause more damage since the osmolytes are less inside the cell, and that will cause demyelination, that is called as osmotic demyelination. So coming into the same concept here, which was earlier was given a box concept, now it is not true for that for all the types of hyponatremia. Since whenever we have the urine, which urine flows, flow rate will be there, insensible loss will be there, and there will be intake of fluid also, orally or IV fluid will be given. So that's why it is not a closed compartment where only the intake will be there and no excretion will be there. So it is not true. So we cannot calculate in the same formula which was given by Dr. Nicholas Medias. So now coming to the free water concept in the urine, how to know that how much urine volume which is passed in the urine contains what is the amount of free water inside. Since if you what is the most important point of SIDH or the euvolemic hyponatremia concept? Restrict water. So that is the first and foremost plan you will be having in that scenario. So you need to know how much has to be restricted. You cannot say that how much the patient might ask you or the nurse might ask you how much water restriction you want, doctor. So in that scenario, you have to calculate by different formulas what is the free water excretion. So let us say that the urinary volume is like this. So always calculate the urinary sodium along with urinary potassium. Alone, urinary sodium will not give you any answer if you want to take a urinary free water estimation. Since urinary sodium will all just guide you only if you are doing that it is a hypovolemic hyponatremia or it is a euvolemic hyponatremia. That is the only cutoff where urinary sodium will help you in that scenario. But calculating urinary free water, you require both electrolytes, that is urinary sodium and urinary potassium. So what is the concept? Let us say that there is excretion of urinary sodium and potassium, and if you push the by this um, by this line and make the urine concentration of potassium sodium equivalent to the plasma, then the which is remaining in the left side is the electrolyte free water. So how to calculate this? The urinary volume in multiplied with urinary sodium plus urinary potassium divided by plasma sodium and plasma potassium. That gives you what is the in the right side of the bracket of the box. What is electrolyte free water? The electrolyte free water is the urinary volume minus this amount. So that is the electrolyte free water. So let us go for some investigation and see how we can manage that patient. So let us say that the patient is having hyponatremia and it is a euvolemic hyponatremia with this SIADH. The plasma sodium is 120 and plasma potassium is 4 and the patient is afebrile. Why I mentioned afebrile is if the patient is febrile, so the insensible loss will be higher. So on an average, around 400 to 500 ml of water is excreted by the insensible loss. And the urinary sodium here is 50 and the potassium is 20. So if you calculate the same thing together, so you in the this right side of the bracket is 1.7 liters. So what is the electrolyte free water in 3 liters of urine volume? So 1.3 liters is the electrolyte free water. Now calculating the loss by the insensible loss, so 1.8 liters. So if you drink 1.8 liters of fluid or hypotonic fluid, then your plasma sodium will remain same, 120. However, if you restrict water less than 1.8 liter, then only the plasma sodium will increase to in the subsequent days or period. So that this is how you have to calculate that how much volume of water restriction is needed. Now coming into the same scenario, the plasma sodium of 120 and plasma potassium of 4 and the sorry the urinary sodium this is the urinary sodium of 150 and one potassium of 40. So if you calculate, it is around 4.6 liters, 3 liters of urinary volume. So what is my 1.6 liters? So what is happening here is whatever water he is consuming or it is getting excreted by the urine from our body, it is getting absorbed. So this is called as desalination, where in spite of water restriction, the sodium will go down further. You will say that I will not give water to the patient. Still, the urinary sodium will go down from 120 to further. So this is called as desalination. Where, why it is very important? Here, either you have to use 3% saline to increase the sodium, or if it is acute scenario, or if you want that the sodium is gradually should be increased, and then you can use the Bhaftans to increase the sodium, since that doesn't the free water basically excretion is independent of this calculation itself. So here it is a scenario where Bhaftans has to be used where the ADH is active. So what are the Bhaftans? Bhaftans are basically a drugs which competitively bind with the B2 receptors, and the ADH moiety, which is obviously will not get attached to the B2 receptors uh, due to that only. And this what are the B2 receptors? B2 receptors or the vasopressin receptors can be divided into several categories, and especially so in three categories. And these are all G protein coupled, and they require phosphorylation and the calcium, phosphorus and the calcium to get stimulated. And B1 is A receptor, B1B receptor, and B2 receptors. B1 receptors are present in the vascular smooth muscles, hepatocytes, renal, adrenal, and the brain cells. It is ubiquitously present. B1B receptors are present in the pancreas and the brain. V2 receptors are present most of the time in the basolateral membrane of the renal cortical tubules, and some uh, in the vascular endothelium. So the selective targeting the V2 receptors will cause more of free water excretion. And what are the drugs which are available now with us? One is the B2 receptors. There are oral formulation and IV formulations. The most common agent which is available to us is Tovactan, and the other formulations like the Tovactan or Tovactan are not available. Tovactan is available in Japan. Tovactan is in the process of third phase trial. Tovactan is available, but it has got action against both 1A and B2. So, what is the implication of this B2 receptor antagonist? Tovactan is the drug which is available in injectable form. So, if you want to use it in less subacute setup of hyponatremia, you can use it. However, Tovactan has been used only in those group of patients where hyponatremia or SIDS, euvolemic hyponatremia is there, and rarely in congestive heart failure, since it has got vasodilatory properties, and that will cause splanchnic vasodilatation as well as intracoronary vasodilatation, and that will lead to heart failure, and sometimes it can cause more trouble in cirrhotic patients. So in cirrhosis, it has been contraindicated, basically Tovactan. Whereas Tovactan has less, it is a more selective form of Vaptan, which only acts on the B2 receptors, and in acute setting, it is of since the onset of action is very slow, it takes around 4 hours to reach the Qmax. So that's why acute setup, it is of no use. So whenever you want to use it, it is either for subacute setup or chronic hyponatremia. And if the patient is symptomatic hyponatremia with CNS maladaptation, so in that scenario, Tovactan should not be used. Also, Tovactan should not be used in case of uh, um, just a minute, in hypovolemic hyponatremia patients. So hypovolemic hyponatremia is absolute contraindication for use of Vaptans. Then what are the other agents which can be used in hypervolemic hyponatremia? One is if the patient will be in, let us say that you want to balance the water and the salt excretion, the best way will be to use diuretics as a loop diuretics. But if in certain scenarios you cannot use it, you want only free water excretion, then you can use tolvaptan. Whereas conibaptan can increase the blood pressure as well. And if the patient is having uh, dilutional hyponatremia, you can use conivaptan. And the other one, B1A and B1B receptor antagonist, I don't have any good information about them, so I will not comment on that. So what is the scenarios where the tolvaptan should be used? As we say that hyponatremia due to euvolemic state or hypervolemic state, we can use tolvaptan or baptans. What is the concept of use of baptans in renal failure patients? Let us say the patient is having creatinine of 3.5. So in that scenario, whether it will work. So theoretically, as you say, that the patient with creatinine value of 3.5 will be having eGFR less than 30. And the baptans usually don't means can it is a relative indication to use in that scenario, since usually it doesn't cause much of free water excretion. Why it is like that? It is due to the loss of medullary tonicity. What I said earlier, the subtle hypothesis, that when your kidneys are already having chronic kidney disease, your tubulo-interstitial structure are damaged. And that causes loss of medullary tonicity. So there is no concentration drive or the between the two sides, basically peritubular capillaries in the apical membrane or in the tube luminal side. So when there is a low concentration gradient, so obviously the subtle hypothesis, the aquaporins will not be effective enough to drive the water into the other side or the peritubular capillaries. So causing so the effectiveness goes down of baptans when there is a chronic kidney disease. Whereas, what are the other conditions where baptans can be used as a therapeutic treatment? One of the few of the trials which have shown that their use are beneficial is in autosomal dominant polycystic kidney disease, where the V2 receptors are a major player of cystic enlargement. And to reduce the cystic enlargement, the baptans are used. And there, the dose of baptans also are very high. Normally, we use the dose as 15 to 30 milligram, maximum 60 milligram in a euvolemic hyponatremia setting. Whereas in polycystic kidney disease, it can go up to 90 to 120 milligram dose. So the second one is that baptans side effects. So what are the side effects of baptans? You can have dehydration, you can have hypernatremia, but those chances are very rare, 1.8 to 2% around. Thirst is intense sometimes, and people used to take more water during that period of time, but it can be managed. Whereas take into in your mind that whenever in ADPKD you want to use the drug of tolvaptan, so in that scenario, if the patient is having thirsty, then ask them not to restrict your fluid intake. You have to be liberal in getting the fluid intake, since In polycystic kidney disease, it is a tubulointerstitial disease. So urine output is not an issue. But if in spite of that you are uh, doing fluid restriction, there will be increased tendency of concentration, liberation of antidiuretic hormones, which the baptans will not be able to uh, antagonize, and then that will cause more cystic swelling and then subsequently damage to the kidneys itself. So in ADPKD, we don't ask them to restrict water unless until there is a contraindication to it, like let us say the heart is compromised or ejection fraction is low in that scenario. Otherwise, we ask them to take normal amount of water and ask not to be thirsty. So there are certain conditions where there will be resistant to baptans, and these baptans are basically if like I said, very high circulating vasopressions where there is antagonism is not achieved, since the dose or the concentration of the drug is not able to antagonize that much of vasopressin. So there the baptan resistance can happen. If in spite of telling the patients to restrict water, they take excessive water intake, then also there will be resistance to baptans. And then vasopressin independent diluting defect. Basically, when told that in case of chronic kidney disease, the GFR, since I said in the first, there are four elements to the water metabolism. That is, one is the first one is the GFR. If the GFR declines, obviously the uh, ultimately delivery of water into the distal tubule also will be less, and that will be vasopressin independent. So vasopressin independent diluting effect, and in certain conditions like in chronic the cirrhotic patients or the patients who are congestive heart failure, they are having intense vasoconstriction, and that causes like hepatorenal syndrome or uh, the cardiorenal syndrome, where the patient's vasopressin level is high, but the delivery of water into the distal part of the collecting tubule is so less, and it gets absorbed from the other side, tubules sides. So the concentration is not having any dependency on the vasopressin. So those are the conditions where baptan resistance happens. So taking into the take-home message of today's talk, uh, what I can tell you is basically baptan should not be used in hypovolemic hyponatremia cases. Baptan's action is not immediate, hence cannot be used for hyponatremic emergencies. Should be used only in slow correction of hyponatremia. You can analyze the blood and urinary parameters to deduce where the fluid restriction will not be possible to correct the hyponatremia. There, baptans can be used effectively. So also the urea. Urea is also one of the molecule which has been used before the baptans were discovered. The urea is, as I said, that it is a hygroscopic molecule, and it is presence itself will cause effective the free water excretion. So we used to give urea to the patient orally to excrete out the free water, and that worked well with those patients also where the tea and toast diet people used to, or the beer potomania or the onco cases, those urea also used to be our main way of prevention of hyponatremia or correcting the sodium. The side effect profile of baptans are less and well tolerated and can be used in hypovolemic hyponatremia settings. Uh, uh, Only thing is, although the documentation of liver enzyme elevation and other things, hepatotoxicity is there, but it is very rare. It has not been very common. So in chronic liver disease patients, there are trials which says that if you closely monitor the liver enzymes and the liver functions, and you can just juggle with the baptans, then you can correct the sodium level and correct the hyponatremia. However, it has not been conclusively proven that correcting hyponatremia in chronic liver disease patients, whether it is beneficial or not. Since whenever you stop the baptans, the sodium level again will go down, and in prognostication also, baptans, whether it causes improvement in the symptoms or clinical outcomes, it is dubious. Conivaptan should not be used in cirrhotic and in ischemic heart disease patients. So, and those patients who are having baptan resistance, those patients who have to be identified and can be dealt in a separate way. Thanking you.